like you can imagine 3 types of stroke you want to know: ischemic, embolic, and hemorrhage. Okay, so those are like the 3 main types. So ischemic stroke is going to be essentially due to high blood pressure. Okay, so uncontrolled high blood pressure, diabetes, because that's going to lead to atherosclerosis, and that also, of course, smoking damages vessels. So that's going to sort of obstruction to an artery, and there's going to be all symptoms often fluctuate, stuttering in progression, improvement. So basically, over here, as the blood flow fluctuates even slightly, symptoms may improve temporarily as some receive blood to function. Then we have over here ischemic, which are emboli, which is going to be your AFib or your carotid from your carotids over here. So there's AFib, endocardial atherosclerosis, BRUI. Onset is going to be abrupt, and there's going to be maximal at start and multiple infarcts. Vascular damage, intracranial hemorrhage, which again is uncontrolled hypertension, coagulopathy, these are drugs, amphetamine, cocaine. And we can see progression over minutes to hours, and we can see focal neurology symptoms appear early, following by features of increased intracranial pressure, vomiting, headache, bradycardia, and reduced alertness. All right, then we can see a spontaneous subarachnoid hemorrhage, the rupture of a sacral area brain aneurysm, or from an AV malformation, severe headache at the onset of neurological symptoms, so meningeal irritation like stiffness. We can see initial management of stroke. So we want to make sure we do ABCs, make sure the airways are fine, make sure our breathing is fine, make sure our circulation is fine. Then we want to do a non-contrast head CT over here. Once we do a non-contrast head CT, we want to then see if there's whiteness, we think hemorrhage. If there's black, we're thinking ischemic stroke. So we want to maybe give permissive hypertension, allow their blood pressure to be high, so they have enough perfusion. And if we have within 4.5 hours, we can give thrombolytics or we can go for thrombectomy. Now, if it's going to be hemorrhage, that's a bit of a different story. So you want to keep the blood pressure not too high for 140 to 60. So when aggressively lowering, if you aggressively lower it, it might compromise the cerebral perfusion in some areas. And we want to reverse anticoagulation. We want to maintain normal ICP. So I want to come here, guys, and really recap for you guys what is stroke. So we have 3 types. So we have ischemic stroke, which is atherosclerosis, hypertension, stroke, diabetes, smoking followed by diabetes, and it can have like symptoms can often fluctuate. That's going to be starting progression because some areas may receive less blood and some may receive more amount of blood. Then after that, we can have the embolic. So we can see this embolic can be from AFib, infected endocarditis, or very, very important over here, your carotids atherosclerosis. It can go up and cause a stroke, TIA, or retinal artery occlusion, also known as amaurosis fugax. Amaurosis means blinding, and fugax means fleeting. Then we can come over here into hemorrhage. Hemorrhage is usually due to high blood pressure. We can have subarachnoid hemorrhage, which is going to be nausea, vomiting, headaches, all of this good stuff. Nausea, vomiting, headaches, which can also be here. How do we want to manage stroke? Essentially, the way we want to manage stroke is going to be through this way. Like if it's ischemic, first of all, do your ABCs, then do a non-contrast CD, not a contrast, non-contrast CD. Once we do a non-contrast CD, we want to see if there's going to be any sort of we can allow blood pressure to be permissive blood pressure, and then once we have allowed permissive blood pressure, we can either do thrombolysis or we can do a thrombectomy. Then we come to hemorrhage. Hemorrhage, you want to make it 140 to 160 because you don't want to like decrease it so much that like we now going to get ischemia, but you don't want to like keep it like that high, of course, because that's the reason we're getting hemorrhage. So we want to do that, and then we want to reverse any anticoagulation and make sure there's no ICP. I just want to show you guys this really nice image of her. Embolic is going to be like a straight line because maximal onset, because you just get embolic and you get obstruction. Atherosclerosis, guys, it's going to be like kind of like fluctuating because as you spoke about, we don't know, like maybe some areas are getting more blood, some areas are getting less blood, so it's kind of fluctuating sometimes. And hemorrhage is going to be progressive worsening because basically over here initial bleed over time is going to be damage the vessels, increase intracranial volume and pressure. Blood fluctuates even slightly. Symptoms may improve temporarily as some areas receive enough blood to function adequately, only to worsen if blood flow is compromised.